Absolutely. My name is Hanna Soukka. I come from Turku, Finland, just on the other side of the Baltic Sea. And I'm here to talk about NAVA-ventilation, which we started in our NICU about 2009. And I would really like to thank the organizers for this possibility to talk about NAVA-ventilation. So I do have a conflict of interest. I have participated as a speaker in scientific meetings and courses that have been organized by Mackay Critical Care. And we have a study group, and the EDI catheters for our study group have been provided by the Mackay company, nowadays called Getinge. So NAVA stands for Neurally Adjusted Ventilatory Assist. And that, to make it short, it means that NAVA delivers assist in proportion to and in synchrony with the patient's own EDI signal. And before we go any further, I need to go through some NAVA terminology. The EDI stands for electrical activity of the diaphragm, and it can be considered as a respiratory vital sign. It represents the patient's neural respiratory drive, and it can be displayed as a waveform, as here, and also on the ventilator screen we can see the numbers. The EDI peak value is this highest value on the waveform, and it represents the neural inspiratory effort. It is responsible for the size and duration of breath. The EDI minimum, on the other hand, is this lowest EDI value on the waveform. It represents the spontaneous tonic activity of the diaphragm, and it prevents the de-recruitment of the alveoli during expiration. So on this slide, I would like to show you how the neural triggering differs from the conventional triggering. In spontaneous breathing, the impulse for each breath is generated in the breathing center. And then the impulse is mediated through the phrenic nerve to the diaphragm, where it excites the diaphragm. And it is right here that this EDI signal is captured and processed and used as a neural trigger in NAVA ventilation. In conventional ventilation, on the other hand, the diaphragm excitation leads to diaphragm contraction, then chest wall and lung expansion, and a change in airway pressure, flow, and volume. And it is here that the trigger is captured in conventional ventilation. So when using the neural trigger, the trigger comes significantly earlier. So in NAVA ventilation, it is the patient that controls over the initiation of breath, the respiratory rate, inspiratory time, peak pressure, and breath termination. And this occurs in synchrony with initiation of breath, size of the breath, and termination of breath. So what is needed for NAVA ventilation is this special catheter, which has 9 electrodes in it, and it is used as a normal nasogastric tube for feeding the infant. Also, what is needed is a EDI module to filter and process the signal, the cable, and then servo I or servo N ventilator or servo U for adults. Here you can see the lower part of the esophagus and the stomach, and the diaphragm right next to it. And the EDI catheter is placed so that these electrodes are right next to the diaphragm. So I will take you through my presentation with these two infants, Camilla, who has been taken care of in servo I, and Ahmed, who was taken care of in servo N. So if you are familiar with any of these ventilators, you can just follow the right or left side of the presentation. These both infants were quite small, 24 and 23 liters. So how to position the EDI catheter? I told that there are 9 electrodes, so actually there are 4 electrode pairs with which you can measure the ECG. And with the help of the ECG, we can have the placement correct. You can see that the P wave disappears when the lowest electrode pair has passed the heart. Also, they have made it easier for us. When the catheter is in the correct place, there is the color change in the second and third ECG curve. And when the catheter is in the correct place, we take it as a normal nasogastric tube. So here you can see the EDI curve for one single breath. To get a nice curve like this, the signal is controlled 62.5 times per second. And here you can see how the trigger is set. It's always set 0.5 over the EDI minimum. Here the minimum is 0.3. So the trigger starts at 0.8, and this is to get rid of all the noise that comes from the surrounding muscles and from the esophagus. Here you can also see how the expiratory phase starts. It starts at 70% of the EDI peak. So here these two babies are switched to NAVA-ventilation. The upper curve is the pressure, flow, volume, and then here on the lowest panel, the EDI signal. And I made these signals a little bit bigger so that you can really see that on NAVA ventilation, the trigger comes from the EDI signal. You can see these different colors in the beginning of the breath. And I have switched here the sweep speed to 5 millimeters per second. And here you can see 40 seconds of breathing. And I think this is so wonderful always to see how irregular the breathing is in very preterm infants. And these breathing patterns have been described by Jennifer Beck. On this slide, you can see phasic breathing, no tonic activity. Here, phasic breathing with tonic activity when the diaphragm doesn't relax at end expiration. Also, apnea with a flat signal, and a sigh after apnea when the infant recruits the lungs. So in NAVA ventilation, it is the patient that determines the peak inspiratory pressure, the respiratory rate, and inspiratory time. And what we need to set is NAVA level, peak, some backup settings in case of apnea, and also the apnea time. And if I start with the NAVA level, here Camilla was switched to NAVA with a level of 1, and Ahmed with a level of 2. So the NAVA level is a conversion factor that turns the EDI signal into proportional pressure. Here you can see the equation, how it's counted. It's the EDI peak minus EDI minimum times the NAVA level added to PEEP. To make it very quick, it's the EDI peak times the NAVA level. So if the NAVA level is 1, this is the proportional pressure the baby will get. And if you double the NAVA level to 2, the pressure is almost doubled. So how we do this, we set the initial NAVA level to somewhere between 1 and 2, and then we switch the infant to NAVA and optimize the NAVA level later. And after we switch the baby to NAVA, the neural feedback will start regulating the breathing. And then we optimize the NAVA level according to the EDI peak value, which reflects the work of breathing, and we target between 5 and 15. So here we have these 2 infants on NAVA-ventilation. The y-axis is from 0 to 20 here, and from 0 to 20 also here. And the EDI peak values are between 5 and 15, so we were quite pleased with the NAVA level here. And next we need to set and optimize PEEP. The EDI minimum, as I told you, represents the tonic activity of the diaphragm. And initially we set the PEEP somewhere between 4 and 6. And then if the diaphragm is constantly activated, then we increase the PEEP. It looks like the EDI curve is kind of floating in the air. And here are these 2 babies again. The EDI minimum value is close to 0, here 0.4, for both infants, as a sign that the diaphragm relaxes at end expiration. And so we thought that these settings, PEEP of 4 and 5, were good for these babies at this time. But then there are some special cases where NAVA does not work, and the most common is apnea, when the EDI signal is flat. And in case of apnea, we have to have these backup settings. For these babies, we chose to have the frequency of 24 and the pressure 10 over 4. And they are 30 and 15 over 5. And here both infants have apnea. You can see the flat EDI signal, and that's when the backup ventilation takes place. Here are longer apnea and some backup ventilation. So we can also set the time after which the ventilator is switched to backup ventilation. So it is called the apnea time, and we set it initially from 3 to 5 seconds. But if the patient is very unstable, then we go down to 2 seconds. And then we have to make sure that the backup ventilation doesn't hyperventilate the baby, and we almost always put the baby on caffeine. So here for these both infants, we chose to have apnea time of 2 seconds. And here you can also see that we take off all the alarms from the ventilator so that the baby and the family doesn't get disturbed by any alarms. So the shorter the apnea time is, the more there is the risk for hyperventilation. And after switch to NAVA, we have to follow very closely to trend curves. How many apnea per minute the baby has, and the percentage of time on backup ventilation. And then these values, the apnea time and the backup settings, need to be adjusted. So what is new in NAVA-ventilation is these very valuable trend curves that give information about the respiratory variables for the preceding 24 hours in servo I and 72 hours in servo N ventilator. And they should be checked regularly. And here you can see Camilla's first hour after she was switched on NAVA ventilation. So the screen is for 3 hours. And she had the EDI catheter 1 hour when she was still on SIMV plus PS support. And this is her NAVA. And here you can see the pressure curve and the significant decrease in pressure immediately after the baby is switched to NAVA. Here you can see her respiratory rate, and after the switch to NAVA, her own respiration comes more regular. And then some more of these trend curves. Here is the EDI tracing, and the EDI peak value becomes a little bit more stable after switch to NAVA. Here is the number of switches to backup ventilation. It's from 0 to 15. So during the first hour with a 2-second apnea time, she was switched from 0 to 8 times per minute to the backup ventilation. But what is important, she didn't get stuck to the backup ventilation, so the percentage of time she was on backup ventilation was quite small. This is Ahmed's first 6 hours in NAVA ventilation. The same was seen in pressure. This is his peak pressure, and a significant decrease after switch to NAVA. The number of apnea per minute, the value is from 0 to 12, and the percentage of time on backup ventilation, and his EDI peak and minimum values. So the same has been shown, the decrease in peak pressure in quite a few neonatal studies already. And also it has been shown that NAVA improves patient ventilator synchrony. So this is Camilla's first day in NAVA ventilation. Here you can still see the very beginning of her being on conventional ventilation, and then quite low pressures she used on NAVA ventilation, and quite stable respiratory rate. Not many apnea per minute, and she didn't spend much time on backup ventilation. Here you can also see her blood gas analysis, which looked very good, and the baby was very stable on NAVA at this moment. And here you can see again some more of these trend curves. This is the pressure and the EDI curve. You can see that it fluctuates, and we learned quite fast when we started using NAVA that we can see how when the nurses are taking care of the babies, every 3 hours you can see a peak in the EDI peak value when they wake up the babies. And when we look at these or evaluate these, we should always find a place when the baby is asleep, when we think of making any changes in the NAVA settings. The patients are weaned off from ventilator by decreasing the NAVA level, and usually the patients are ready to be extubated when the NAVA level is less than 1. So to go to these patients again, Camila, the 24-weeker, she was 3 weeks on ventilator, of which 16 on NAVA. She was 5 days on conventional settings because she needed her ductal to be ligated. And then there is Ahmed, who was almost 3 months on ventilator, about half of this time on NAVA and the other half on conventional settings. And this is for you to notice that they won't make in NAVA all the time during their time in the NICU, but also other ventilator modes are needed. In NAVA, one has to notice that in order to make it on NAVA settings, the child has to have enough respiratory drive. And it is the child that regulates the CO2 level. There is the NAVA level increase does not have an effect on CO2. Then there are some cases when there is no EDI signal, and I talked already about the central apnea and the risk of over-assist or hyperventilation. However, when the baby is switched to backup ventilation, as soon as the EDI signal returns, the baby is automatically switched back to NAVA ventilation. If there is too heavy sedation, there is no EDI signal, or if the baby is paralyzed. And we can also use the EDI signal to diagnose brain injury. And the EDI signal has been used to diagnose central hypoventilation syndrome and also phrenic nerve conduction failure. There are some contraindications. If the baby doesn't have sufficient respiratory effort, like brain anomaly or medication, in esophageal atresia or congenital diaphragmatic hernia, you cannot insert the catheter before the operation. Phrenic nerve injury or congenital myopathy, and also before MRI scanning, we need to remove the EDI catheter. There are also some limitations that I need to mention. The NAVA ventilation is limited to only one brand of ventilators. And there is the cost, an extra cost for the EDI catheters. And also a lot of training is needed to train the whole NICU staff for this new type of ventilation. And long-term effects are not yet known. NAVA has been used as a diagnostic tool to help in the clinical work. I already mentioned the congenital central hypoventilation syndrome. NAVA has been used to wean difficult patients. Others and us, we have used NAVA when we wean congenital diaphragmatic hernia patients. And what is quite important is that during NAVA ventilation, which is triggered by the patient, him or herself, we need less sedatives. So we started NAVA in October 2009, and we are using it as our primary mode of ventilation for all neonates who are ventilated or whom we plan to ventilate more than 24 hours. And this is because of the cost of the EDI catheters, that we don't insert the catheters to those patients that we intubate and give surfactant and plan to extubate shortly. Here you can see the numbers, how many patients we treat. We started there 2009, and now we have stabilized to treat 50 to 60 patients annually on NAVA. We also have this NAVA research group or baby-friendly ventilation study group, and we use the EDI signal in our study group to assess work of breathing and work of breathing during different respiratory support modes, the effect of different ventilator modes on physiology, and the effects of medications, and also the effect of the implementation of NAVA on our clinical outcomes. Here are two publications in which, with the EDI signal, we showed that it is as easy to breathe on prone position as in kangaroo care compared to supine position. And also we showed that the effect of caffeine citrate is mediated neurally, and it shortens both short and long apnea. With the EDI signal, we have shown that the high-flow nasal cannula has its own place between CPAP and no respiratory support when we wean premature babies from respiratory support. So I would like to conclude about the advantages of NAVA ventilation. It is gentle because the assist is delivered in proportion to and in synchrony with the patient's EDI signal. For the first time, we really can optimize the PEEP with the help of the EDI minimum value. We can continuously monitor the respiratory drive for the patient, how many apnea per minute, and the percentage of time the patient is on backup ventilation. And we can optimize the pain medication to give adequate medication without any respiratory depression and decrease the need for sedatives. And the last but really not the least is that we can increase comfort for these patients, and this has been reported to us by both the parents and the neonatal nurses. I would like to thank you by showing this picture of our NAVA research group. Thank you.